The next presentation will be given by Kristin Verbeke from the University of Leuven. She is a well-known scientist in the field of gastrointestinal function testing. She has contributed also very nicely and very extensively to the guideline process, and she will give a presentation on 13C breath tests with relation to gastric function and H. pylori infection. Kristin, please go ahead.
Today, I would like to talk to you about the two C13 breath tests that are used to assess gastric function. And the first one is the C13 urea breath test to detect Helicobacter pylori infection, and the other one is the gastric emptying test. I will be short about the C13 urea breath test because it's a standardized test and well-known test, and I would like to spend some more time on the gastric emptying breath test. So although the golden standard to detect Helicobacter pylori is still histology from biopsy samples, the urea breath test has become a valuable alternative because it achieves more than 95% sensitivity and specificity both in adults and children. And in this way, it is appropriate for all indications for Helicobacter pylori testing. Standard protocols normally use 75 milligrams of the labeled urea together with citric acid, and breath samples are collected at baseline and after 30 minutes after the administration of the urea. And most often an increase of 4 per ml over baseline is considered as the threshold for a positive diagnosis of H. pylori infection. To avoid false negative results, it's important that some medications are discontinued, and especially proton pump inhibitors should be stopped for at least 7 days, but preferably 14 days. H2 antagonists can reduce the sensitivity of the test for about 2 weeks, and antibiotics and bismuth compounds that are used in the eradication have to be discontinued for 4 weeks. So a control test to confirm eradication should not be performed within 4 weeks after the end of the therapy. And that brings me to the gastric emptying tests that are used to objectify gastroparesis. So in adults, symptoms that indicate gastroparesis are nausea, vomiting, early satiety, postprandial fullness, bloating, and upper abdominal pain, provided that mucosal and structural disease has been excluded. Also, unexplained impairment of blood glucose control in patients with diabetes might indicate disturbed gastric motor function. In children, only the symptoms nausea, vomiting, and abdominal pain are indicative of delayed gastric emptying. Now, the golden standard for gastric emptying remains the scintigraphy with a technetium-labeled test meal, but C13 gastric emptying breath tests have been successfully validated towards scintigraphy and have become an established alternative. The main advantage of these C13 breath tests is the fact that they use stable isotopes instead of radioactive ones that do not confer any radiation burden to the patient. And secondly, that they can be performed remotely. So the patient can do this, for instance, at home with analysis of the breath samples later in the lab. So you do not need the expensive equipment for scintigraphy. In contrast, the breath test is only an indirect test. It does not measure the emptying of the label from the stomach. It measures the appearance of the label in breath and estimates from those data the gastric emptying. Now, test substrates and test meals have mainly been copied from the scintigraphic tests. So in scintigraphy uses standardly scrambled eggs with bread as the test meal. So it was also the most obvious one to be used in the bread test. Octanoic acid was chosen as the substrate because it showed firm retention to the proteins of the egg yolk in the stomach. So octanoic acid is not released from the egg yolk in the stomach and leaves the stomach together with the solid phase, which is of course very important. And it is only upon arrival in the duodenum that then the egg yolk will disintegrate and octanoic acid is released and can be absorbed. Later on, many alternatives for the test meal have been developed, like pancakes, muffins, or rolls, depending on cultural preferences and practical consideration. But that means that in Europe, there is no standardization of the test meal. Each lab uses its own test meal and has had to develop its own normal values. So that means that values from one lab cannot be compared to values from another lab. In contrast, it allows quite some flexibility and, for instance, for research projects to test gastric emptying rates of very diverse test meals. In the US, C13 labeled spirulina is most often used, and that is the biomass of cyanobacteria or blue-green algae that have been grown in a closed environment with the C13 source, so that they have a high enrichment in C13. So the spirulina is also incorporated in an egg mix and administered together with some crackers in a standardized protocol that have been approved by the FDA. The spirulina leaves also the stomach together with the egg, and it is only after digestion in the small intestine of the cells, of the algal cells actually, that the C13 label is released and can be absorbed. When the gastric emptying rate of liquid meals has to be assessed, normally the water-soluble C13 acetate is used as a substrate and just added to the liquid phase. Now, a patient that needs a gastric emptying breath test need to be fasted. Normally, adults are fasted overnight for at least 12 hours. In children, a little shorter period can be allowed. 8 to 12 hours can be sufficient, and infants less than 12 months of age should only be fasted for 3 to 4 hours. Interference from other C13 sources needs to be avoided. So C13-enriched foods or infusions have to be stopped before the test. Physical activity during the test is not allowed because that alters the CO2 production of the patients, but also alters the gastric emptying rates. And drugs that interfere with gastric motor function should be discontinued unless the aim of the test is to evaluate the impact of those drugs on gastric motor function. Furthermore, the patient has to be in an upright sitting position because a supine position delays gastric emptying. And after collection of the basal breath samples, the test meal needs to be consumed within a period of 10 to 15 minutes. This is important because the mathematical modeling of the results assumes that the test meal arrives in the stomach as a bolus. Of course, a perfect bolus is not feasible, but at least the eating time should be limited. And after consumption of the meal, breath samples are collected at fixed time points, normally every 15 minutes up to 4 hours, but there can be some variability depending on the protocol. Now, to analyze the data, in the original breath test, Hoos actually used the scintigraphic analysis as the example. So in scintigraphic analysis, here at time 0, 100% of the label is within the stomach and then starts to decline following this function that is described in this formula. So in breath testing, the amount of C13 that accumulates into breath follows the reciprocal curve of the scintigraphic curves, except that it will never reach 100%. And for that reason, this parameter M has been included here in the formula, which is the amount of C13 recovered in breath at time infinite. And then the C13 excretion curve as a function of time is presented here, which is actually the first deviation of this curve. So based on this model, you can calculate a half emptying time and a lag phase in exactly the same way as you do it for scintigraphy. So the half emptying time is the time at which half of the amount of at time infinite is excreted in breath. And the lag phase is here in scintigraphy, the time corresponding to the inflection point in the curve. Here also the inflection point, and in this curve then it is the time of maximum excretion. You see from the formulas here that these parameters only depend on the shape of the curve and not on the height of the curve. That is because the parameter m is not incorporated here in the calculation formulas. So that implicates that, for instance, if you do not know exactly the amount of substrate that has been administered to the patient, or you cannot exactly estimate the CO2 production, it is not a problem. That these factors only determine the height of the curve, but not the shape. The only assumption that you make in this test is that CO2 production is stable during the test. That makes that those parameters are quite robust parameters to be calculated. Goos also proposed an alternative model. This is what you can see here. And this is a model that is only based on the characteristic shape of the CO2 excretion curve, and that corresponds to the gamma functions. So you can use such a type of function that you can see here to model the data. Based on this model, you can also calculate a half emptying time and a lag phase. But the model also allows to define a kind of the gastric emptying coefficient, which is then the ln of parameter 8. So this is this parameter here, this in the formula. And this gastric emptying coefficient is a kind of global estimate of gastric emptying rate, because it is determined by both the ascending and the descending slope of the curve. So the main drawback of this parameter is that it does not have any biological meaning, so which makes it more difficult for interpretation. And also, this parameter does depend on the height of the curve. So if your estimation of the CO2 production is not correct, for instance, that will have an impact on the gastric emptying coefficient. In that sense, it is less robust than half emptying phase time and lag phase. Now, as I already mentioned, the breath test is an indirect test and measures the time at which the label appears in breath, not the time at which it's emptied from the stomach. Now, as the physicians were used to gastric half emptying times provided from scintigraphy, Goos proposed to correct for those post-gastric processes, and he correlated both the half emptying time and the lag phase from the breath test with that of simultaneously performed scintigraphy. And you see that there was quite a nice correlation, and using this correlation, you can convert the T half and the T lag from the breath test to the corresponding values from scintigraphy. Now, such a correction assumes that post-gastric processes is constant amongst individuals. The group has confirmed that by administering octanoic acid directly into the duodenum of individuals and then measuring the appearance of the label in breath. And they confirmed that there was very minimal inter-individual variability in those processes. And also in insulin-dependent diabetes patients and in patients with severe liver cirrhosis, the post-gastric processes remained unaffected. Nevertheless, others developed later on alternative procedures that do not need such a uniform correction for to calculate the scintigraphic half emptying time. And for instance, the gastroenterology unit at Mayo Clinic used a generalized linear model. So that is a purely mathematical model that predicts the scintigraphic gastric half emptying time from linear combinations of C13CO2 concentrations in breath at specific time points. And the model also incorporates gender and BMI as covariates. So in this way, you can estimate the scintigraphic half emptying time, and you see here that there is quite a nice correlation also between the breath test and the scintigraphy that then was performed simultaneously to validate this model. The main advantage of the model is that it requires a lower number of breath samples to be analyzed. And this model is currently used, for instance, in the US for the analysis of the spirulina test. And then a final method is the Wagner-Nelson method that is less frequently used and that originates from pharmacokinetic research. So the aim of this model was to improve the breath test analysis by correcting for a number of potential confounders, which are retention of the C13 label in rapid turnover bicarbonate poles, fixation of the label into metabolic products, and loss of the label via elimination via non-pulmonary routes. So what happens here is that the rate of absorption of CO2, C13 CO2 in the systemic circulation is considered as an index of gastric emptying rate and is estimated from the rate of the pulmonary elimination of the C13 CO2. So the assumption here is that the absorption of octanoic acid and oxidation to C13 CO2 proceeds so rapidly that it is negligible. Also, this method has been validated towards the scintigraphy, albeit in smaller cohorts. So the take-home messages of today are that the C13 urea breath test is highly accurate and appropriate for all indications of H. pylori testing, that due to lack of standardization in test meal for gastric emptying tests, the values from different labs cannot be compared. So each lab has its own normal values and cannot be compared to other ones. Normal values only apply for the specific test meal and the specific test conditions that have been used for the development of the normal values. And different mathematical approaches that have been developed and validated towards scintigraphy should only be applied using the standard conditions in which the validation studies have been performed. So thank you very much for listening and for your attention.